what we're going to cover today is a few objectives, 3 simple ones. Linda, if you want to move on to the next. We're just having a few technical issues, people, so if you'll forgive us as this is a bit awkward. But anyway, we'll keep rolling. So our objectives. Hopefully, by the end of this conversation, you'll love evaluation as much as I do. We're also going to look at how data can be used in evaluations, because I'm sure a lot of you have used data before for quality improvement, but the purpose of what we're talking about and what you're funded to do for your nurse-led clinic is really to get some change in place and evaluate how it goes. Then the final part is really how do you keep your nurse-led clinic alive? And to do that, you're going to need data, and you're going to need to enable people to understand that data so that change happens all around you. And hopefully people across the country want to use your nurse-led clinic model. So there are 3 broad objectives. On to the next slide. Do we want to move on to the next slide? There we go. Okay, so I'm going to confess right up front that I've fallen in love with data. So for me, in my clinic, I know that data isn't the route to an easy life, but it's certainly the route to a better life. And the reason we've started falling in love with data is because even though we're in the people business of healthcare, we need to deliver evidence-based care because money's in short supply, staff are in short supply, so we've really got to go with what the data is telling us. So if you start understanding evaluation from the perspective of how do I get the most out of the limited resources we have, and how do I go home at night knowing that I've done a great job, data is your answer. The other thing that we've really started talking about in our clinic is how data makes us able to make a difference, or MAD. So we talk about how we're a MAD group. The other things that have become common to us, and we've moved on to this next slide from Deming, is that data equalises the field. I know in a lot of our practices we have some fairly historical figures that might control the debate. We might have some fairly strong clinicians that like to control the debate too. But what we've started doing is getting a level playing field by using data. And all of a sudden you've got people concentrating on the same thing rather than what they've got to give up, what the history is, how important they are as a doctor, or anything like that. And all of a sudden we can have better and more robust conversations. On to the next slide, Linda. So I just wanted to point out, because I'm sure so many of you have been involved in reporting on your clinical placements, doing quality improvement, and perhaps this is the first time that you've really got involved in a new initiative and evaluating it. So where does all of that sit on the data collection and analysis sort of bell curve that we've got in front of us? So on the very left, we talk about how if you're doing something, you want to know you're doing it well, and that's control. Are we delivering to the standards, to the benchmarks, to the clear clinical indicators that are important? So that's control, and you want to make sure that you as a nurse are doing great stuff just like the nurse beside you is doing awesome stuff. Then you might want to go, could we do what we're doing better? And that's quality improvement. So for that, you also need data, because you want to show where we are now and where we've moved to over time. But it's really about managing incremental change and movement over time. The area that you're playing in is you've invented something entirely new. It's never been done in your clinic before, so there's probably not a lot of baseline data and historical data. So all of a sudden you're wanting to say, is my invention worthwhile? And that's the difference between improvement information and evaluation reporting. So if we go on to the next slide and look at Joseph Juran. It's also starting to say, well, if we're evaluating something, there's a number of pieces to that evaluation. So the first thing is we need to plan what it is that we're evaluating. So where are we headed? What are we hoping to achieve? How will we know if we've even got there? The second part is, if we do get there, is what we're delivering quality? Is it worthwhile? Have we climbed a mountain that even makes sense? And then the final part of your evaluation is the acknowledgement that nobody gets it right the first time. So as you go through your project, you'll see that your productivity improves, your systems improve, a whole bunch of stuff gets better. And that's because you're taking the time to ask the question, to say, I did this, maybe that wasn't perfect, how else could I do it? And that's the quality improvement piece. So in the reporting and in the data that you're gathering, you actually need to be able to report against those three parts of the triangle. What did we plan? Did we get there? Was it quality when we got there? And how did we tweak it on the way through to make sure that it got better and better? On our next slide, we're looking at change. So you can get to the top of your mountain as much as you like, but if you haven't brought people along with you, then they're never going to change. And the whole purpose of funding these clinics and these pilots is to get other people to want to change with you. So again, as you're starting to think about how am I reporting my information, you need to start thinking about, is there a particular number that it's going to be a killer number? And it might be, if you're doing a diabetes clinic, and I know a few of the pilots in the past have focused on diabetes, so let's use that. All of a sudden, you go from having 50% of your population way above the HbA1c of 7, and then all of a sudden through your initiative, you've got 75% of your patient population who are hitting HbA1c targets. That would be a killer number. So you can collect other numbers, but that's the number that shows that your service, your initiative had a really clear advantage over what had gone before. So think about that, because no doubt you're going to be measuring multiple things, but which is the one thing that is the number that people are going to gravitate towards and get really excited about. The other thing you need to think about is whenever we're changing, we're challenging the status quo. So how is what you're doing building on the values of your clinic? So your clinic presumably says we want to deliver safe and high quality care for our patients. So how can you find numbers and data and stories and other things that actually make that story come true? We've delivered on our values. We've exceeded what our organisation says we're good at. Other things that are important about change are when it's simple and easy to implement. So as part of what you're doing, I know you're starting to document what you've done, what's your model of care, what you had to do to get up and running, all of those things, because if it's simple and easy, other people will be more interested in doing it. The final thing is, can you look at whether it can be tested? And no doubt in the early months of your system, you've made some little steps and tried to get a few things moving before you rolled out the whole agenda. So again, look at some of the numbers, some of the data that might come out of that, your own testing, so that other people, when they decide to go and do this, can also see whether their numbers start looking like that before they make a full commitment. And then finally, can other people come in and have a look at what you're doing? That's observable. They'll get convinced. You might be able to take some little videos or something like that, so that when you're presenting on your clinic, people go, awesome, I could see myself doing that. So on to the next slide. We're going to talk a lot about data, but I want to say up front that data is wrong. And I know a lot of you as nurses would much prefer to be spending your time face-to-face with patients doing the caring stuff. And sometimes it's easy to get hung up on why the evaluation isn't perfect and the data isn't perfect. We know that. So what we're going to say is that data does not automatically equal quality, but it's really hard to have quality without good data that shows us what we're doing. So if we then move on, I know most of you have been working with Linda around a program logic. So this is what you've been funded to do, what you're going to do, and exactly what it delivers. And it's broken down in a whole series of columns that for some people might seem a little odd and unusual to look at. To me, this is heaven. This is where I get my logic right. I can see whether I do this, whether that feeds into that, and then ultimately it delivers something worthwhile. So what you're trying to do through your program logic is capture what are your inputs, what are your outputs, what are the outcomes that all of that activity delivers, and why is that valuable? That's the story that you've got to be able to tell to your stakeholders, internal to your clinic and external. So sometimes when we're thinking about what we'll measure, all that we measure are the inputs. I spent so much time and so many hours. That's not really that interesting. Or we might go, oh, I could measure the outputs. We saw so many patients. Okay, that's interesting. But does it tell me what happened to those patients? Does it tell me why that's valuable? So that's why when you were looking at your program logic, it forced you to start upping the ante and getting bigger data sets so that you'll be able to answer the so what questions that people come at you with. If you get too much of your data just from how many hours you've spent, how many patients you've seen, you won't be able to answer the so what questions. And they're the ones that will convince people around you to embrace what you're doing. On the next slide, this is just another way of saying what I've done. If you can collect data against all of those things, all of a sudden you'll have a more convincing story. So what might that mean? So your inputs, I've already mentioned time. You might have money that you've been given and that the practice is added. You might have costs of consumables. So all of these things are quick, easy things to measure. But you'll then have activities. What's been enabled to happen? So how many total clinics or how many total sessions or days or cycles of care or bigger picture things did you deliver? How many nurses were even hired to do this? So these are the activity type things. Then you've got your outputs. So I've mentioned the number of patients seen, but what might be more interesting is what about the time between appointments? What number of things were done with each patient? Did you do more foot checks and eye checks and blood pressures and heights and weights and measures and things? So you can have a whole series of outputs that you can collect information on. But where you'll have the killer data is about the change that you've made. So what resulted from your activity? So if you can prove reduced hospitalizations, reduced GP visits, for example, in a clinic where you've got too few GPs and too many patients, or people being able to spend more time at work, or having lower out-of-pocket costs for medications, or whatever. All of those bigger picture things, this is where you start getting people's attention. So think again about your program logic, and what are the things in there that are both easy to measure and worth investing time to measure. So on the next slide, once again, we're talking about how will you know if your project's successful? And ultimately, it needs to answer that so what question. So you might have created a wound clinic. So your problem was that you wanted to deal with diabetic foot ulcers and skin tears and a whole bunch of other wounds in your clinic. So you had an undifferentiated population with lots of wounds, and you didn't know how many of them there were. So your input was to start organising that care by giving some nurse time. There was some money that funded that, and there might be a number of different services. that came out of that to deal with different sorts of patients. What could you measure and count? Well, obviously the number of wounds dressed, the number of patients who came, the number of actual individual patient attendances, and the number of patients who were enabled to do more self-care perhaps. But what's the really big crunch data? How many wounds were healed? How many wounds had to be referred on for perhaps vascular surgeon attention or something? How many amputations ended up happening? And how many deals perhaps were you able to do with suppliers so that all of a sudden your patients got access to much cheaper silver dressings and things like that, so that more wounds were healed at cheaper cost with fewer visits to your GPs? All of a sudden that's a bigger picture story. And then ultimately, what big contribution did that make? Well, reduced hospitalizations perhaps, reduced patient shame about how smelly and ugly and everything else they were, maybe returning to work, doing more activity because they were able to, and that might have a better impact on their heart health or something. So all of a sudden you've got the move from very easy data to more complex data, but it's data that tells a story. So on to the next slide. What you're doing, hopefully, through your clinic is innovative. And the sorts of things that clinicians are interested in are twofold. What happened to patients? But most importantly, how was it done? Because if I'm trying to convince people to keep funding this or to take up this model somewhere else, I need to know more, not just about the what, but the how. So this is where you might start thinking about a couple of really simple and easy things you can measure around not just what you improved, that's what we've been talking about so far, but which factors influenced that success. Was it important that I had dedicated time for 3 hours every Friday morning and everyone knew that that was when my clinic was? Was it important that I had a particular GP as the sponsor who would unbreak things and get rid of the blockages and really sponsor this? Was it that I was able to form that partnership with a wound supplier to bring down the cost of wound care to patients? I don't know. There'll be a whole heap of factors that are particular to what you're doing. And then the final thing is, how did I have to innovate the processes in my clinic? So did I create a whole new way of booking? Did I bring in some new equipment and have that used differently? Did I create some different patient education tools? Or what else could you innovate as a service? Did I get patients teaching other patients? There's all sorts of things that are inherent to the service that will have an impact on why it was innovative and why it worked. So again, as you're planning how you write up your story, and ultimately every evaluation is just a story, it's not about data. If you can pick data against each of those three areas and weave it into an interesting story, it will mean that your clinic becomes much more observable, interesting, and easy to understand for your stakeholders. So moving right along, I'm a big believer in being lazy. So let's look at simple measures, things that you can do without a whole lot of effort, and you might do them at the beginning of your service and perhaps at the end of your service, so that you're not chewing up a heap of time on the way through. So everyone wants to know what they've done is quality. An easy way to test that is, were patients satisfied? And there's a whole heap of validated patient satisfaction tools out there that you can find. There's perhaps even some particular to wound care, diabetes, aged care, whatever it is that you might be doing. There's also clinical outcomes that have been specified in evidence-based journals. They might be in clinical guidelines, whatever. So that HbA1c and 7 is a well-validated target. So the question becomes, how many people hit it? You can then move on, and at the very beginning of your service, say, well, how are patients cared for now? What does it cost? In the first few months of me delivering my service, what did we deliver? How much did it cost? And then write again at the end, what did we deliver? How much did it cost? And you can come up with 3 different average costs per service. So it's not something you need to do the whole way through, just at certain points, and you end up with some interesting data. Same with revenue. How much income had we earned in the previous 3 months prior to what I did? How much revenue were we earning in the final 3 months? Reliability is also something that we need to make sure happens in our services. So did we reduce errors, for example? Patients who weren't brought back for certain sorts of care that was in the guidelines, and by having your clinic, all of a sudden those patients were getting what they should have been getting all along. Did we reduce the amount of time that it took for them to get access to a service? So if at the moment they're heading off to hospital and it takes them 6 months to get in, and all of a sudden there's a 3-week waiting time at your clinic, that sounds awesome. And again, you'd measure that before you started and at the end of your service. You don't need multiple points of data all of the way through. What about access? Have you got more LGBTI people involved? Have you got more elderly people involved? More called people? More young people? Whoever it is that might have an access issue, can you see that you've increased the reliability of service provision to that group? Finally, what about skills gained? Have you done things? Have you systematized things? Have you documented things so that it's all very easy rather than ad hoc and something that people have to carry around in their head? Other things that are quick and simple. How long did it take you to see each patient on average? How long did they spend waiting for you to get to see them whilst they came into the clinic? Did it go from an average 40-minute wait to 15 minutes? These are all simple pieces of data that only need to be done periodically. On our next slide, where can you get some of this data if it's so easy to find? Well, we've got patient charts that have huge amounts of information. So we can use patient extraction tools like PenCat or Polar, and we can say we want to see all of the patients with diabetes, and all of a sudden we can very quickly look at them, see how many of them are sitting at this certain HbA1c we might want to look at, how many of them had a blood pressure, height, weight, eye check, those sorts of things in the last 12 months, because there's tools that exist to pull that information out of patient charts. Perhaps in your disease area, PenCat hasn't been built to do that yet, so you might have to do an audit of patient charts. But if you've only got 50, 100, 200 patients, perhaps that's possible in your time frame. The important thing when we're looking at patient data is to make sure that we're always using the same report and we're collecting the information in the same way, or else all of a sudden you can be reporting apples and oranges without knowing it. Another thing that we can use are practice management systems themselves. They all have reports. So in our practice, we use best practice. It can report on waiting times, the number of patients with certain diagnoses, the certain billings by clinician, lists of patients who attend very frequently or who are the highest revenue costs or whatever. There's about 70 reports that you can pull out of best practice, and then there's ones you can generate yourself. So again, use some of those reports rather than manually collecting data and entering them into a spreadsheet. Validated tools are out there as well. I'll talk about one now and then we'll go into it in more detail. So patient activation measures is something I particularly love. How can we find out how health literate patients are, what's happening in the social determinants of health for that patient, and how interested they are in their health? The PAM measure, which is an American tool, will allow you to do that and be very predictive about how much support that patient's going to need. Likewise, there's heaps of depression scores, memory scores, pain scores, etc. that you can use and just enter those results as a key piece of data. If you're more sophisticated, you can then go into your practice data in whichever system you use. So again, we use best practice. We know how to go into best practice and extract information using some little codes that we write in best practice. And we, for example, can tell you that 17% of our patients who were offered a care plan refused it in the last 12 months, because we've been able to look at words that are in patient notes, extract that information out and do a report on it without having to do an audit of every single patient history and note-taking exercise. Now, that's going to involve a few more skills, and you probably don't need it for the purposes of your evaluation. But if you've got people who are keen coders and really big data people, that's something that you can explore and investigate because it is there. And then finally, you could generate your own data. You could do surveys with your patients. You could come up with your own tool that you use to assess against. You might be able to look at costs and billings and all of those other sorts of things. It really depends upon what your questions are and whether the return on your effort is going to be worthwhile. My suggestion is that you start using some of those earlier ones because the data will probably be more reliable, much easier to access, and it's going to be the same data time on time, particularly if you've got multiple people working in the clinic. So it removes the bias of some of that. On to the next slide, quality. We all say we deliver quality care and we want to know we're developing and delivering quality. And there might be some people in your practice who are a bit disturbed by what you're doing. Doctors, for example, who are going, a nurse couldn't possibly do it as well as me. So how could you satisfy them that what you're doing is quality? Again, let's look at some things that you can pull out and answer questions that we know they're going to have. So is it safe? Have we avoided harm? And you might be able to say, well, we did more medicine reconciliation, or we had more up-to-date medication lists, or we did more biomarker collection. We had more accurate diagnoses. There's a whole bunch of things that you could use that show what you're doing is safe. Is it effective? So this is going back to the evidence base for what should be happening and then showing how often we did that. So have you done more asthma cycles of care? Have you increased your rate of pap smears? Have you got more of your patients who've got a mental health diagnosis also having regular heart health checks and things like that, because we know that they're often going to die of bowel cancers and heart attacks than they are of suicide? Is it patient-centered? Have you helped establish a relationship with the patient, their family and their carers that really allows the patient to have choice? So you could talk about the shared decision-making tools that you used and how more of your patients chose not to have surgery, whereas before your intervention, most patients were heading off and having major knee surgery or whatever. Likewise, was it delivered at a time that suited patients by a person of gender or orientation that suited them? So you can describe those things. Was it timely? So again, we've talked about waiting times and the harm that can come through delayed access to care. Can you demonstrate that? Is it efficient? Have you saved costs somehow? And finally, is it equitable? Who's getting access to care that wasn't previously able to access care? So these are all simple counts where, so long as your patient history taking is accurate and you've got information in the patient charts, all of a sudden you'll be able to say, well, more of our elderly people or more of our LGBTI people or whatever, more of our Indigenous people started attending this service. On to the quadruple aim. So I'm a big passionate advocate for us looking at everything we do in healthcare through the quadruple aim lens. So I'm really pleased that the first thing they ask is, what's the patient experience? We've talked about patient satisfaction measures. We've talked even about, could you collect some patient journeys? So talk to some patients who've been in care for the last 5 years before your intervention started. Get them to map what their journey looked like and what went wrong and what went well. And then do the same thing with them after your services started. And that patient journey and that story can be used to convince people that you have made real and meaningful change. At a population health level, Have we got better clinical outcomes? Have we done things that are going to stop people from getting disease? So if you're targeting a youth population, have you done more sexual health screening, given them access to more contraceptives, and perhaps done some screening around depression and anxiety? And that will have positive outcomes in terms of suicide, preventing pregnancy and STIs. Have we reduced cost? We're in the business of constantly reducing cost in healthcare. And finally, have we made work more satisfying? If we've added to the joy of being at work, then all of a sudden the quality of care and the likelihood of keeping people doing that care goes up. And if people are happy, the patient experience is also going to be better. So is there a way of surveying your team members and asking them about what care's like now, what stresses them, what worries them, and then doing that at the end and demonstrating that people are happier at work? So let's move on to that first piece, the patient experience. So patient-reported experience measures, so PREMs. Could you use a happy or not system in your clinic where people tap on a button on a tablet, or they've got other little machines that are on stands where you click on some coloured little buttons and patients tell you whether they're happy or not? That's a patient-reported experience. Could you get patients to periodically just do a quick little survey against 2 or 3 questions and ask them to rate things? Can you get patients to report on what's happened to them? And again, ton of validated surveys and instruments out there that you could use. So I'd very strongly recommend that if you look at the literature and see who's done something innovative in your area in the past, use the same sorts of reporting tools they've used, and that way you've got a benchmark you might be able to refer to. The final part is these patient activation measures. Why am I so excited about them? Well, if we look at America, where they came from, and also the NHS in the UK, they've been able to show through really, really large studies that if you can move a patient just one category in a patient activation measure spectrum, you can save hospital admissions. So if you collect a patient activation measure at the beginning of your service and then again at the end of the service, and you can show that they've moved up one category, all of a sudden you can use the literature that's out there to say, well, potentially I've saved so many hospital admissions, or potentially I've saved so many lives, or so many diagnoses, or whatever. So it's a really powerful tool simply because of how much research has gone on behind it. The other thing that I love about it is it tells you information you might not know about your patients. So what's going on in their lives, what's their health literacy like, what are the barriers that they face in caring for themselves. As you understand that, you can offer more personalised care. So you might take a little more time with this patient because they've got a really low PAM score, educate them, support them, coach them a whole lot more, and all of a sudden you get better outcomes. Whereas someone with a really high PAM measure, you can just hand over a few brochures, say these are the 3 things that you need to do, and they'll go away and do it. It's a very different patient interaction. If we move on to other easy data that's out there, because remember I'm the laziest researcher known to mankind, your PHN will produce a heap of information on a regular basis. They have to. The Commonwealth requires it. So get a hold of their needs analysis and see whether there's information in there that's pertinent to what you're doing. Then you've got a baseline you compare against. State governments also produce annual or biannual reports about a whole bunch of health information. See whether you can, again, use that information to demonstrate the need and why it's growing or not growing or whatever. And then you can paint your story using that data and how your data is different. The Australian Institute of Health and Welfare, they control a lot of the Australian Bureau of Statistics health-related information, as well as massive data sets beyond that. What's even better is they have a fantastic website that you can go in and you can look at data from a PHN level, at a council level. They're called sort of SA3 regions. So a much smaller level that's local to your practice. And you might be able to identify that in your region, you've got far higher preventable hospital admissions because immunisations are not happening in the over 65s or something. You can then run your intervention, and because they do update their data, in 3 years' time, you might be able to get access to data that shows that key piece of information has changed. And if you're one of the largest providers in your region, and I know in a lot of rural areas that might be the case, all of a sudden you might be able to claim some credit. There's also a lot of reports that are done by the Asthma Foundation or the Heart Foundation or goodness only knows who else. Try and find those reports because they'll have a richness of data there, and you can compare what you've done versus what that data tells you. And then finally, there's a lot of companies with a vested interest out there. So talk to your local pathology collection service, drug companies that might sell drugs into this market, etc. And you will be amazed at the amount of data you can get out of them, which again can become part of your baseline or your comparator. And you can use that to tell your story. So what is your story? Moving on to the model for improvement. So some of you might have seen this before as part of your quality initiatives. And it really says at the beginning, what are we trying to do? So hopefully you've already thought that through and you've defined your model. How will we know the change is an improvement? So by implication, you're asking what's the baseline, what happens at some point, and what happens at the end. So you need to be collecting data a number of times. Your challenge is to say, do I need to collect data daily, weekly, monthly, quarterly, annually? My suggestion is less is more. So rather than collecting huge amounts of data all of the time, pick a couple of points. Give yourself a bit of a run-up. No clinic is going to be perfect in the first 3 months or so. So if you collect information at the beginning and then you don't collect it again for another quarter or 6 months, that's fine. And it'll mean that the amount of work you're doing goes down. Another way of putting together in diagram form what your story might be is to use a driver diagram. Sorry if it sounds as though I'm speaking with marbles in my mouth, but on the phone line that I'm using, everything I say echoes. So that's sort of interrupting my brain a bit. So on the next slide, we've got a driver diagram. So let's say you've decided that the problem in your service is you've got too many people sitting in the waiting room and it's driving everyone nuts. So to solve that, there's a number of things you could do. You could triage patients differently. You could make sure there's more doctors available. Time of year, you know, it varies. You could talk to patients about how they book and what they book for and whether they book long appointments. You could look at your no-show rate, and you could even look at how patients are being managed by doctors. But say, for example, you decide the biggest challenge around waiting time in your practice is that every time it's winter, flu rates go up, and that just causes your waiting room to go nuts. There's things you can do about that. So do all of a sudden I start having some walk-in clinics that are run by nurses? Could I have nurses doing more triage so that it's not up to reception to determine who gets those valuable appointments? Could we do more to promote the flu vaccine? Or could we bring in a temporary Defence Force registrar for 3 months just to give us a bit of extra capacity? So you might have run through a similar sort of what drives change, what's really important to get a different outcome as you've been thinking through your clinic. I'd encourage you to write that up, and then as you're doing it, it'll become more obvious what you need to measure. So in the case of this one, if we decided that we were going to promote more flu vaccines to try and reduce the overall rate of infection, well then that would be our key number that we would need to promote and collect. It also will help you as you're describing your story of why you created your clinic, if you've got a diagram that looks a bit like this, to talk through what you did and how you did and why it worked. On to the next slide. Quality again. So if we use that example of we want to reduce waiting times, our aim is that we want to improve the patient experience. We want less grumpy patients who are harassing reception and not having a memory left by the time they finally get to see a doctor. What's our concept? So what are we trying to improve? Well, we've decided we're going to reduce waiting times. So what can we measure? Average waiting times per doctor, average waiting times per nurse, per allied health person, whoever. And best of all, we can get that data straight out of our practice management system reports. But before we do that, we need to know exactly how we're going to define waiting times. Because waiting times can be done differently. Is it about the amount of time patients spend in the waiting room? Is it about the number of patients who arrive early, who also crowd out the waiting room? There's a whole bunch of things that we might want to make decisions about. So you might want to actually come up with your mathematical model of exactly what it is that you're measuring, so that at every point, everyone knows what it was that was measured. So in the case of waiting time, we've said, okay, we're going to add up all of the time that patients spent in excess of the time that they were supposed to be seeing a doctor. So they had a 10 o'clock visit, but they didn't get in till 10:15. That's 15 minutes. And we're going to divide it by the number of patients seen that day. It's a fairly simple mathematical model. We're then going to collect that data. So we might collect that data every single day for 4 weeks and report it by an average across the practice and an average by doctor. We're going to run the report straight out of BP. We're going to put all of that data into an Excel spreadsheet, and we're going to see what that data tells us. If it tells us something interesting, we might take action. How do we know whether it's interesting? Well, let's go on to the next slide. So patients get harmed when they can't get access to care or the diagnosis is not great. They get harmed when we don't provide appropriate treatment. We're not following the guidelines. Treatment itself can have complications. So you might get scarring, you might get infections, a whole range of things. Patients might be over-treated, and that can have complications. There might just be general harm that arises. So, for example, you give an immunisation, you might get a small fever, you might get a bit of pain, you might get dehydrated from certain drugs that you're taking on a hot day. And finally, there's the psychological harm. So, have patients become too attached to a person? Have they decided that this is all their fault and that this disease is really something they can't control? There's a whole bunch of things that can add up to psychological harm. So depending upon what your service is, these are some other things that you could tap into and see what you could measure. And this is how you'd go about doing it. So if we move on to the next slide, it talks about PICO. So you need to define who your population is, what you're going to do, what your comparator is, because if you're doing something and you don't know whether it's different to anything else, it's hard to measure. So the comparator could be what was happening in the clinic before your service and afterwards. It could be just your part of the clinic versus the rest of the clinic that might not have changed. Or it could be your clinic versus average population health data in the region. And then finally there's outcomes. And you can look at the differences between what you've done and what was happening before or elsewhere. And the way you would do that is by looking at the next slide. So you'd collect a whole bunch of data. Generally, you'd put that data into a spreadsheet and you'd be looking at that data over time. So in this instance, we've got 30 data collection points. So if you're running your service every week, you might easily come up with 30 data collection points for a patient or a series of patients. So this is called a run chart. And what you're really looking for is every day things are going to vary a bit. But what's sort of the mid-range? And that's called the median on this chart, because we're trying to look for patterns. If we then move on to the next slide, this shows you if I've collected data from before my clinic began, and then I've got a purple line, which is when my clinic began, can I see that there's a change in the data by just following it over time? If it does, I start getting a bit exciting, but the next slide will tell us whether that change is meaningful. Firstly, is there a shift? For there to be a meaningful shift, you need to have at least 5 points of data that are all heading in the same direction. Just one data point is not enough to show that anything significant has happened. You need at least 5 to have something that's really starting to show you something's interesting happening. The second rule is, are those things happening in the same direction? So is it all going down? Is it all going up? Does the data seem to follow a pattern? The third rule is what's called the interocular test. So just by looking at it, does something look weird? Is there a major standout, something that is obvious in the data? Oh, perhaps that's the day we didn't have any computers running, so of course waiting times blew out. Or perhaps that's the month that you had holidays. So all of a sudden, something that looks weird can be explained because there was another factor at play. And then finally, was there anything that seemed useful? So this is where we're showing a repeated pattern. Sorry, again, I'm getting my words mucked up because I keep hearing myself twice. So are there useful observations? So at the first week of every month, the data always drops or it goes up. All of a sudden, we've got a pattern that we can observe. Well, what happens in the first week of the month? Or what happens during school holidays? These are the things we've got to explore. So on the next slide, I'm encouraging you for the slow game. Always make sure you've got more data than less, but keep it reasonable. So if we're trying to put stuff in a spreadsheet and see if there's a trend, we need a minimum of 15 to 20 patients, or 15 to 20 days where we delivered the service, or 15 to 20 weeks, or whatever. 15 to 20 is where we start seeing something that's noticeable. On to the next slide. So noticeable means there's variation. So is that variation due to something that's real, or is it due to something that's weird and unexpected? So if it's something that's quite real and predictable, it's called common cause variation, because it's always going to happen. There's something common about what's occurring. If there's special cause variation, so all of a sudden it's show holiday and that only happens once a year, it might be harder to know what drove that change. But that's where you, at the coalface, managing your clinic and looking at this data, will hopefully be able to make sense of it. If it's special cause variation, it might not be so important to take into account in the future, because show holiday only happens once a year. So down to the next slide. Once you've got your data, you need to be able to look at your data and answer these questions. Does the data tell us whether the intervention worked? Does the data tell us how that was achieved? So if all of a sudden you're having less hospitalizations, how was that achieved? Well, we saw patients more frequently, we did more testing and measuring and support, more education, whatever it was. That's the how. What resources did it take? Well, presumably it's your time, some consumables maybe, some resources, some new equipment you used, whatever. But every time you do something, the world's a bit chaotic. There will be an unintended consequence. So you did this, but this also happened. So you offer a new service, and all of a sudden all of the oldies in your population decide that you're their very best friend, and they're also going to start talking to you about another diagnosis they have. You might not have predicted that. And it's instead of spending less time with patients, you start spending more time with patients because you're dealing with multiple things rather than the one thing you set out to do. And then finally, how did we compare? To ourselves, to another practice, to the region, perhaps to some research that you found that was published. The reason I'm giving you a number of slides like this is for a lot of you, the thought of writing up your evaluation is probably terrifying. It's all very well to get some data, but what am I going to do with it? So by looking at some of these slides with these types of questions and prompts, hopefully it's going to make it easier for you to know, what should I be measuring? How do I explore it? How do I write it up? And how do I use it to convince people? In the final part of what we're going to talk about, we're going to talk about some things that I know make a lot of clinicians nervous. So onto the next slide. Have we delivered things that are effective and efficient? So this is going back to the Quadruple Aim, where we're asking ourselves about population health as well as cost. So what data would we need to prove that this was financially beneficial for our practice or financially beneficial for the patient, that it had clinical benefit, that it was even competitive, because it might get attention in our patient group and attract more patients or attract more clinicians if they're in short supply. Were there team benefits? And most importantly, were there patient benefits? So the team benefits might be the number of people who had late finishes or were back at work doing a whole heap of paperwork or didn't have lunch or they had no-shows and that drove them nuts. Did they feel more supported? Did we keep more of our staff? Could we ask our staff about job satisfaction? In terms of patient networks, or patient benefits, sorry, did patients get more reminders, more education? Were they made to feel special? Did they bring their friends? Were they less likely to run out of medications? Were they able to do more things for themselves? So these are all different breakdowns of things, some of which you can answer with story, some of which you can answer with fact. So let's have a look at some of the facts. The financial case for change is on the next slide. So this is just some simple data to give you an example of how you might outline the difference in cost between what you've done and if you allowed a GP to do it. So the data I've pulled together here is about doing chronic disease care planning. So if you've got a doctor alone and they're seeing patients and they see 5 patients an hour and they bill a level B or a 23, your average MBS allowing for a bit of bulk billing incentive item and stuff in there, they might be billing $129 an hour. If the GP does care planning, all of a sudden they can see few patients, but they can bill some bigger item numbers, so they can bill $142 an hour. But what happens if all of a sudden the nurse spends time with patients? The doctor can see more patients, but you can still bill that big item number. The cost of the nurse is $26.40, say, for the 40 minutes. We've billed $168, and the difference is $39.60. So the difference in billings has more than paid for the cost of the nursing time. So by putting things in a table like this and being able to manipulate data, you've got a financial model that will hopefully be able to show what you've done. So you might need to use revenue, you might need to be able to use staff time and the costs of that time. You might even be able to talk about how the waiting room is not as full, so we don't need to extend the practice and pay more rent. I have no idea what your financial case for change is going to look like, but I know that if you can put in a table and say, here's the components, here's before and after, it's much easier for people to believe you than if you have a number in a sentence that says it used to cost us $80, now it costs us $60, and everyone's happy. They'll want to know how you came to that conclusion. And this is sort of a bit of a simple way of putting it together. On to the final couple of slides. Project success indicators. On the way through, hopefully you're doing reporting to your practice manager, your GP owner, your service owner, whoever it is, about what's really going on in the project. Because you're not the only one that makes the project a success. So again, I'd encourage you to almost use a bit of a diary where you can talk about what's going on. And the first thing that's going on is, are people being accountable for what they've said they'll do to make this work? If the expectations are not clear, or people are saying they're doing things but they're not doing things, that makes it really hard to be successful. In terms of the people element, who was on site and who wasn't? Who did what they said and who wasn't? Who was available and wasn't available? In terms of the things you had to play with, did you have the right space, time, systems, computers? Were you able to blend this into tasks that made sense? All of this is good story that you can use to show why things worked really well or perhaps didn't work as well as they could. Did you deliver on target? Does the need still exist, or have you solved this problem? Were there lots of risks that you had to confront, and how did you do that? In the information sense, was the feedback positive from everybody? Was there lots of publicity? Did you have enough time? And were people still motivated and energised towards the end of the project? Again, this is all good story stuff, some of which you'll be able to put data around. On our next slide, here's something that we've used in our tea room. It's not quite what we've used in our tea room because I couldn't reduce it down in size, but you can pull stuff like this off the internet. So you could simply ask patients if you want to, or you could ask staff, how do they feel about what's going on? And just get them to circle, and then just take pictures of this and add up how many different sorts of faces were circled, how often. And this is a good way of getting staff and patients involved, so that you've got some real-time feedback. Our second last slide. On the way through your evaluation, I'd encourage you to think about which bits do I share and when. So do I share data every 6 months, every 3 months? Because the more data I share at the right time with the right people, the more often I can solve problems and get people championing what I'm doing. Do I put it up in the tea room? Do I use graphs? Or do I just wait for the final report at the end? Do I give it to all of the staff or just some of the staff? These are all questions only you can answer based on your knowledge of who you're working with. Certainly, as we've got more data active and evaluation in our practice, we start sharing information earlier than we ever used to. We put it up very publicly. We discuss it in staff meetings and other meetings so that we're quite transparent, because people have got used to seeing data and really being engaged with it. But you might need to take people in your clinic on that journey. So see how you go. Talk to Linda and her team, because they've got some experience around this sort of stuff. And it's better to have information out there and get people asking the questions on the way through, so that you can go back and go, well, what do I need to measure, and include that in my evaluation, rather than doing the whole service and the whole evaluation and then realising you missed something. So finally, we've reached the end. My advice is keep calm, love the data because it is your very best friend, and realise that by being organised and reporting on all of this stuff, you're actually helping yourself be successful, not undermining your success. So it's going to be challenging, threatening, and probably new for a whole bunch of you. But by persevering, you'll find things, particularly in your practice management system and what it can report on, that you never knew existed. It'll change your life and make your work a whole lot more happy and satisfying into the future.